Hi all, welcome to today's session. Today we are going to discuss about the topic cellulitis and erysipelas, which are both acute bacterial infection of the skin. They are common clinical conditions, but it is very important to distinguish them from other causes of red, swollen, and painful limb. The major difference is the depth of infection. Cellulitis involves the deeper dermis and subcutaneous tissues, whereas erysipelas is a more superficial infection involving the upper dermis and superficial lymphatics. So, both can produce redness, warmth, swelling, and pain, and patients may also develop fever and other systemic symptoms. The important part of this topic is recognizing the infection early, starting appropriate treatment, and identifying the situations where the patient may have a more serious infection. So, by the end of this lecture, you should be able to define cellulitis and erysipelas, and you should know the common bacteria responsible and understand the major risk factors. And you should be able to recognize their clinical appearance and, importantly, distinguish cellulitis from the erysipelas. We will also discuss how we diagnose these infections when investigations are done, are needed, and how antibiotic treatment is selected. Finally, we will discuss complications and prevention of the recurrence. So, when you see a patient with red and swollen limb, think systematically what is the diagnosis, how severe it is, and what is the source, and is there any red flag suggesting a deeper infection. So, moving on to the overview of today's topic. So both the cellulitis and erysipelas are acute bacterial infection of the skin and underlying tissues. The main difference is anatomical. So the cellulitis, as we discussed, it involves the deeper dermis and subcutaneous tissue. Erysipelas involves the upper dermis and superficial lymphatic vessels. So both commonly produce erythema, warmth, or swelling, and tenderness. The patient may also develop fever, chills, malaise, and regional lymphadenopathy. The most common organisms are beta hemolytic streptococci, while Staphylococcus aureus is particularly important when there is a purulent disease or an abscess. So, clinically, don't focus only on the color of the skin, look at the border, depth, presence of pus, and systemic symptoms. What is the causative organism? The most important organisms to remember are beta hemolytic streptococci and staphylococcus aureus bacteria organism. So streptococci are particularly important causes of non-purulent cellulitis and erysipelas. Staphylococcus aureus becomes particularly important when we have a purulent infection or abscess. MRSA or methicillin resistant Staphylococcus aureus may need to be considered depending on the patient's risk factors and local antibiotic resistance patterns. Some infections can be polymicrobial, so this is more likely in special situations such as diabetic foot infections, animal or human bite, in ischemic wound, chronic ulcers, or severe immunosuppression. So, we should not automatically assume that every red swollen lesion is caused by exactly the same organism. Now let's discuss the why some patients develop cellulitis more easily. The most important factor is the break in the skin barrier. So this can be something as small as a cut, fissure, or a ulcer or wound. One very important, sometimes overlooked risk factor is tinea pedis. Fungal infection between the toes can produce maceration and fissuring. So these small cracks provide an entry point for bacteria. Other risk factors, which include chronic edema or lymphedema, obesity, diabetes, and venous insufficiency. Other risks. So, a previous episode of cellulitis also increases the risk of recurrence. And next, other risk factor is immunosuppressant patients may also be at increased risk. Therefore, when evaluating cellulitis, don't just treat the infection. Ask why did this patient develop cellulitis? Identify the risk factor, which will help to prevent the next episodes. Moving on to the clinical features of the cellulitis. So cellulitis typically produces an area of poorly demarcated erythema. The affected skin is warm, swollen, and tender. The infection usually affects one limb rather than both the sides. The skin may become very tense or shiny because of the edema, and the patient may also have lymphangitis or enlarged regional lymph nodes. Then there are systemic symptoms depend on the severity. A mild infection may produce only local symptoms. More severe disease which can cause fever, chills, malaise and tachycardia. The key visual feature to remember is cellulitis usually has an ill-defined or poorly demarcated border. So this contrast with the erysipelas where the border tends to be sharply defined and raised. So that is the difference between the cellulitis and erysipelas. So when we discuss about the clinical features of erysipelas, so erysipelas is a more superficial infection. The classic appearance is here is bright red, raised and sharply demarcated plaque. The border can look almost sharply drawn compared with the cellulitis, and it commonly affects the face or lower limbs. There may be a significant edema and pain. Systemic symptoms can be prominent, and the patient may have fever and chills. Regional lymphadenopathy can also occur. So, the easiest clinical distinction is erysipelas is superficial, bright red, raised, and sharply demarcated. Cellulitis is deeper, more poorly demarcated. However, there is a considerable clinical overlap, so we should not become overly dependent on these distinctions. So, when comparing the cellulitis versus the erysipelas, this we can this slide will summarize the main difference. So cellulitis involves the deeper dermis and subcutaneous tissue. Erysipelas mainly involves the upper dermis and superficial lymphatics. Clinically, cellulitis generally has a poorly defined border. Erysipelas usually has a raised and sharply demarcated border. Both can produce warmth, erythema, edema, and tenderness. Both can also cause systemic symptoms. So, if you remember only one thing from this slide, deep and poorly defined is cellulitis, and superficial, raised, and sharply defined is erysipelas. So, but remember that real patients don't always follow the textbook descriptions exactly. Now, the history key questions. History taking is extremely important in such cases. First, ask the patient when the symptoms started. Cellulitis and erysipelas often develops relatively rapidly. So ask whether the redness is progressing quickly. Then ask about the fever, chills, weaknesses, or other systemic symptoms. Next, look for a possible portal of entry. So possible portal of entry, and ask about the questions like if there is any cut, wound, insect bites, trauma, injections, surgery or other procedures. And also ask about the tinea pedis because the infection may enter through the fissures between the toes. And also ask about the previous episodes. If the patient has recurrent cellulitis, so we need to look for underlying edema, lymphedema, venous disease or fungal infection. Finally, ask about the recent antibiotics and previous resistant infections because these factors can influence the antibiotic selection. So that is how what that is so these are the questions you have to ask the patient while taking the history. So based on the history you can diagnose the condition properly. So cellulitis and erysipelas are primarily clinical diagnosis. So we assess the appearance of the skin, extent of infection and systemic condition of the patient, and we should check the vital signs, particularly temperature, heart rate and blood pressure. And we should carefully examine the affected area for abscess, wound, ulcer, bite or other portal of entry. And routine blood investigations, routine blood cultures are generally not necessary in an uncomplicated patient. However, you can go for cultures which can become useful when there is a purulent material that can be sampled, or when the patient is severely ill or has an unusual risk factors. So the most important principle here is don't delay the treatment while waiting for unnecessary investigations in a typical uncomplicated case. If the disease is extensive or it is recurrent or it is a complicated case, you can go for the other important investigations or routine blood cultures, which will be very useful when prudent material is available. So that is about the diagnosis, and now we'll discuss about the differential diagnosis. So several conditions can mimic cellulitis. The first important differential is deep vein thrombosis, particularly when there is an unilateral swelling and pain. DVT does not usually produce the same pattern of superficial inflammatory skin diseases or skin changes, but the distinction can sometimes difficult. Venous stasis dermatitis is another important condition. It is usually chronic and may affect both the legs. Next is contact dermatitis, which can also produce redness and itching, particularly if there has been if has been exposed to a particular product. And eczema and other inflammatory dermatosis in other inflammatory skin diseases which can look similar. And next is gout or acute inflammatory arthritis, which can cause a very painful red swollen area around the joint. And the most important dangerous differential is necrotizing soft tissue infection. So that case, necrotizing soft tissue infection, that is an emergency, surgical emergency. So these are the differential diagnosis. Next, the red flags when we have to suspect the necrotizing infection. So this is one of the most important thing from a safety perspective. If the patient has a pain that is much greater than what the skin appearance suggests, think about a deeper infection. Another warning sign is a rapid progression of swelling or erythema. Bulle, skin discoloration, necrosis, or skin anesthesia are concerned. Crepitus may indicate gas in the tissue. Systemic toxicity is another major red flag here. And patient may become hypotensive, confused, or severely unwell. Necrotizing infection can progress very rapidly and it requires an urgent surgical assessment. So don't manage a patient with suspected necrotizing infection as a simple cellulitis. The key point here is pain out of proportion with rapid progression and with systemic toxicity. It is an emergency evaluation. Okay, so these are the red flags you should be aware of when you suspect the necrotizing infection condition. Moving on to the treatment. So once the bacterial cellulitis or erysipelas is suspected, appropriate antibiotic treatment should be started promptly. So the antibiotic choice depends on several factors like severity, purulence, allergic history, local resistance patterns, and patient-specific risk factors. For a limb infection, elevation can help reduce swelling. Pain and fever should also be treated. One simple but useful clinical technique is to mark the border of erythema. This allows us to monitor whether the redness is expanding. But remember, the redness may not disappear immediately after treatment begins. We should also identify and treat the portal of entry. For example, if there is a tinea pedis between the toes, treating it will help to reduce the future episodes. So that is how we have to treat it uh, in the antibiotic treatment, which should be started promptly. And next is antibiotic therapy principle. So treatment depends on the severity. A patient with a mild non-purulent infection who is otherwise stable may often be treated with an appropriate oral antibiotic. If the infection is more severe or associated with significant systemic illness, intravenous antibiotics may be required. And if there is any abscess or other purulent collection, antibiotics alone may not be enough. And drainage is another important component of treatment. MRSA coverage should not automatically be added to every patient, and it depends on the presence of relevant risk factors and local recommendations. The treatment duration should be individualized according to the patient's clinical response and applicable guidelines. If the patient is worsening or not improving as expected, don't simply continue the same antibiotic. Reassess the diagnosis, look for an abscess and a resistant organism or any kind of deeper infection. So, according to that, you have to treat it accordingly. Moving on to the management of predisposing factors. Treating the current infection is only half the job. We also need to manage the factors that allowed the infection to occur. If the patient has tinea pedis, treat it. If there is any fissures between the toes, address them. And if the patient has a controlled edema, or a chronic edema or a lymphedema or appropriate edema. Appropriate edema management should be done. It's very important. And venous sufficiency, venous insufficiency, you have to manage. It should also be addressed. Diabetes, it should be appropriately managed. And chronic ulcers and wounds, it require proper wound care. And maintaining the skin barrier is also important. So remember, if you treat only the if you only treat the cellulitis and ignore the underlying risk factors, recurrence is more likely. So these are the management of predisposing factors of the conditions. Most uncomplicated cases respond well to appropriate treatment, mm, but complications can occur. An abscess may develop, the infection may spread through the lymphatic system, causing a lymphangitis or a regional lymphadenopathy. In more severe cases, bacteria can enter the bloodstream and cause bacteremia or sepsis. Repeated episodes which can contribute to chronic lymphatic damage and worsening the lymphedema. The most serious local complication is a necrotizing soft tissue infection, we have discussed in the previous slide. When the infection involves the face or the areas around the eye, there can be additional complications. Therefore, location matters. A patient with a facial or periorbital infection needs careful assessment because complications can be potentially serious. How we can prevent the recurrence? So, some patients develop cellulitis repeatedly. So, in these patients, we need to identify the underlying cause. First, examine the feet for tinea pedis and treat any kind of fungal infection. Second, manage the chronic edema or lymphedema appropriately. Compression therapy, it may be useful for selected patients once the acute inflammatory episode has settled and when clinically appropriate. Then comes the venous insufficiency. So venous insufficiency should be managed, and diabetes and other relevant medical conditions should be optimized. And the patient should also protect the skin from unnecessary trauma and maintain the good skin care habits. And if a patient continues to have recurrent episodes despite the addressing these factors, specialized assessment may be required, and in selected patients prophylactic antibiotics may be considered. So this is how we have to advise the patient, and we should know ourselves that how we can prevent the recurrence of this cellulitis and erysipelas condition. So let's summarize whatever we have done today. Let's quickly revise the whole topic. Cellulitis is a deeper bacterial infection involving the dermis and subcutaneous tissue. It generally has a poorly demarcated border. Erysipelas is more superficial and typically produces a raised, sharply demarcated red plaque. Streptococci are important causes of non-purulent infections, and Staphylococcus aureus becomes particularly important in purulent infections. Diagnosis is mainly clinical. Treatment involves appropriate antibiotics and management of the portal of entry. And always remember the red flags for necrotizing infection. Finally, recurrence can often be reduced by treating the tinea pedis, edema, lymphedema, venous disease, and other skin breaks. So, to conclude, whenever you see a patient with a red, warm, swollen, and painful area of the skin, don't immediately assume that it is a simple cellulitis. First, assess the morphology and border, then ask about the onset and progression, and look for a portal of entry such as a wound or a fungal infection. And also, you have to assess for the systemic symptoms. Then ask yourself, like, could this be cellulitis or erysipelas or DVT or contact dermatitis or something more dangerous such as a necrotizing infection? The most important clinical message is cellulitis is usually deeper and poorly defined. Erysipelas is more superficial and sharply demarcated. And if you see any rapid progression, severe pain out of proportion, bulle, necrosis, crepitus, or systemic toxicity, treat it as a potential emergency. So overall, the approach should be recognize the condition, assess the severity, treat appropriately, and identify the portal of entry and prevent the reoccurrence of the condition. So that is about today's lecture regarding the cellulitis and erysipelas. I hope you got an idea regarding the topic and how you have to the difference between cellulitis and erysipelas and how we have to differentiate them, and what are the clinical features we have discussed, and what are the red flags you should be aware of. All things we have discussed today. So that's it. So thank you so much for patient listening and have a nice day. Thank you.